Here we go. Thank you everyone for being so gracious with your time and patience. I not only do gynecologic oncology, but I'm also a palliative care doctor. In fact, this is my palliative care clinic office at the Cancer Center, and today was my palliative care clinic day. Today is my palliative care hat, and on 4 days of the week, my hat is gynecologic oncology. So I'm so excited to talk to everyone about what palliative care is and what hospice care is. Let's flip to the next slide, please. I want us to start with a deep breath. And the reason I put this here is because there's a lot of suffering going on in the world right now. And I want to acknowledge that there is a new war. We have seen unprecedented suffering with the brutality against people of color, LGBTQ people. We have seen suffering with COVID. Amid all of this complex suffering, we are also managing cancer for ourselves or for others. And so I want to take a minute to take a deep breath before we engage in this conversation about really hard topics on top of everything else, to give ourselves some space to breathe and to de-stress our bodies and release some of that collectively, and honor with gratitude who's shown up today and who continues to do the good work and support each other and our patients and our mentors and our colleagues. So let's do a collective breath together, okay? On the count of 3. 1, 2, 3. Breathe in. So we're going to enter this conversation, and I'd like us to be active in our chat. We're going to flip to our next slide. Let's chat about and take the temperature of the room for who's here right now about what is palliative care and hospice care. Like in your 10-second opinion about what it is, if you could put it in the chat, and then I'm going to kind of read some of those answers out, because I'm just curious what everyone thinks. Keeping the patient comfortable, comfort care. Palliative care is easing pain and comfort. Hospice is end of life expectations. Palliative care is supported for anyone. Okay, pain management for palliative care, end of life for hospice care. So it sounds like, as I'm going through this list, that actually you all are sounding like experts in this already. So I'm talking to a really savvy crowd, which is exciting. And I hope I can add to that knowledge and answer any like special questions that you have. I have slides like put together. And also I would offer that you can, if you want, you want to interrupt me and ask a clarifying question, I invite you to do that, because I would like us to be in dialogue. I also have tried to keep it short so that we can also answer the questions that people already submitted towards the end, but I want us to be in dialogue. So Tracy, let's advance the slide. Here's what most people think palliative care is. So on this slide, we see the Grim Reaper with a stethoscope marching through the palliative ward, and we see some mouths open. He's our new palliative specialist. And I would say most patients, when they come to my clinic for palliative care, either don't know why they're here, or they think that I'm going to talk to them about dying and that they're not going to get any more treatment. And so what I want us to kind of focus on is thinking about what really is palliative care versus hospice care. So next slide, Tracy. So in my mind, I stole this, what every woman needs to know from an HPV vaccine campaign, because I think palliative care is what every woman needs to know about. And I asked some of my patients who had GYN cancers that I took care of in my palliative care clinic to answer some questions about what palliative care is to them, because I think it's really helpful to hear things from the words of people who have actually walked the journey. So let's flip to the next slide and ask Dorothy and Petra. So Petra, I asked her, how would you describe palliative care to another patient? And she said, before I received palliative care, I had the wrong idea about it. I thought it was hospice, end of life care, and that made me afraid. There needs to be more education about what palliative care is. It's not something you have to be afraid of. You have to have a serious illness, but the earlier you do it, the better. Next slide. So if we take a step back and think about what palliative care is, oh, sorry, for some reason it advanced again. Can you go back to that other slide? There we go. The palliative care grew out of something called the modern hospice movement that happened in the 60s. Dame Cicely Saunders was this incredible person who created a specialty care for the dying. And so a lot of people still believe that palliative care is hospice care or care of the dying. But what I want to share with you is that it's grown into so much more, because what we have learned is that if we apply the same concepts of care to people much earlier in their serious illness, that not only can they live longer, but they can live much better quality of life. And so the current definition of palliative care, also known as palliative medicine, is specialized medical care for people living with serious illness. It focuses on providing relief from the symptoms and stress of serious illness, whatever the diagnosis. The goal is to improve quality of life for the patient and family, and palliative care is provided by a team of palliative care doctors, nurses, and other specialists who work together with the patient's oncologists in the cancer center, for example, to provide an extra layer of support. And it's appropriate at any age and at any stage in a serious illness, and can be provided concurrently with curative intent. Next slide. So Dorothy says, when I ask her, how would you describe palliative care to another patient? And she says, they seem to be experts in quality of life and managing symptoms. It doesn't matter if you're currently in treatment or not in treatment, and it doesn't have to be at the end of life, although it could be. And so if we flip to the next slide, Tracy, thank you. So this is a really good model of how to sort of separate them. Okay, so palliative care, while they share that concept of an interdisciplinary team with hospice care, palliative care is for all with serious illness at any time, whereas hospice requires a prognosis or time expectation of less than or equal to 6 months of life if the disease follows its usual course. And you must forego you cannot receive any further disease-directed treatment. So chemo, radiation, things like that. Palliative care can happen as a consultation with doctors or nurse practitioners in a hospital. It can happen in an outpatient clinic, like here at the cancer center in my clinic. It can happen at nursing homes, but hospice care most commonly happens at home. And it can happen in also a variety of settings, like hospice facilities, inpatient hospice units, depending on the level of care you need, but the most common place is at home. Palliative care is paid for like any other doctor or nurse practitioner visit through your insurance. Hospice care is a Medicare benefit, and it requires certain things of the agency. And if you are not Medicare eligible yet, then it's also modeled in the exact same way with commercial insurance payers. Okay, next slide. So if it's not just death and dying that we do, what do we do in palliative care? And this is how I feel about palliative care, the chill reaper, in the sense that I want to flip it on its head. And this reaper is wearing tie-dye. He's saying, dude, why so grim? chillax. Looks like Shaggy's all freaked out. What I do in my palliative care clinic is cultivate joy, humor, laughter, a space for all of the hard stuff, but also a space for us to enjoy each other and focus on quality of life. So we're going to flip to the next slide. When I think about palliative care assessments and like what I do with my patient in the clinic, we talk about that extra layer of support. If you say your oncologist is in charge of the center of this circle, the cancer-directed therapy, I take all of that other stuff off their plate, because in my oncology visit, I'll change my hats and talk about what I think about and the time I have to spend. In my oncology visits, I'm reviewing labs, I'm reviewing CT scans, I'm reviewing treatment, chemo, surgery, toxicities, and my head is living in the cancer-directed therapy space, and I have very little time to explore and treat and nourish all these other spaces. And so when I put on my palliative care hat, I get to indulge in everything around the cancer-directed therapy. I don't have to take blood tests. I don't have to take vital signs. I get to talk about symptom management, check in with caregivers, think about your social health, your physical function, your emotional health, your spiritual health. I get to talk to you about time if you want to talk about time and how much time you have left and why that's important to you. I get to talk to you about values. You know, what's important to you and how does that affect your choices with treatment and what you're going to do moving forward? How do you cope with this cancer when we're living longer with cancer? So what I think about palliative care visit as is I help you think about and empower you to control what you can control in your life, and I use different strategies and tools to do that. So Tracy, next slide, please. So I asked Dorothy, what do we do in our visits together? Because it's this secret space. Nobody knows what we do. So Dr. Spuzek and her team talked to me about quality of life. That's her number one concern. They want to make sure I'm not in pain. I can eat, I can sleep, I have energy. Then we talk about what's best for me. We discuss the pros and cons of treatments and clinical trials, for example. Next slide. So like I said, I don't take vitals, I don't take labs, but I do use tools to assess how people are doing over time. And this is our ritual in our palliative care clinic, for example, so that we actually know what's going on. Because we found in research actually that if you don't ask specifically about a symptom, that people will not tell you how they're doing. Many times, especially in my gynonc clinic, for example, maybe that's because that might mean no further treatment, or I might adjust a dose, or I might say, let's try something else. So there's a lot at risk with sharing that information with your doctor, in my opinion. And also it's another reason why, for example, I will send my patients to another palliative care doctor for care, because I think there's a conflict of interest. Because when we show up for oncology care, we usually are presenting our best selves. And when we show up for palliative care visit, I want you to express your most revealed self, because I want to be able to really dive in and help you figure out where in your world we can help you feel better and live better. So in this is a scale that we use routinely, the Edmonton Symptom Assessment Scale, to assess all these different symptoms. And then over time, we track them and see how are the different tools or interventions or medications, how are they affecting these scores over time? Next slide, please. So if someone stabilizes in their symptoms, the next thing I like to think about is how can we reframe and rethink about what your goals are? And I actually think a lot of palliative care outpatient clinic is about coaching and life coaching, and thinking about what am I moving towards and how am I keeping myself accountable in all of these domains of my life on a daily basis or on a long-term basis. And so we work together to think about how we can do better for where you are in your body right now and where you want to be. This tool that I use not infrequently actually was made by a patient and their caregiver because of our conversations. And actually now I use it all the time in my palliative care clinic as just a suggestion of how you might frame your goal setting for yourself. One day, 1 week, 1 year, what are your goals? How do you move forward and still having a vision of the future in the body you have right now? Next slide, please. So I asked Dorothy, has this changed your relationships to be involved with palliative care? Yes, it's helped my family relationships. Dr. Spuzek was able to calm my fears, and then I was able to pass that information and feeling on to my children. It helped them understand and get in a place where they can accept what is happening. I could turn around and use her words to talk to my children, and I think it's helped them treat me differently. They respect my wishes and understand that I'm not doing something wrong. Something that's really important is that in the palliative care visit, we invite family to participate. The caregiver is just as important as the patient in our visits. And so I think that this is a place where a lot of communication can happen that may not happen at home, and or we can help you with words to talk about what you're going through. Next slide. One thing that we know, and this is actually, I think, the biggest growing group of our patients is people who are living either with maintenance therapy or living with cancer. And I say that importantly, not dying from cancer, living with cancer, living on the order of an unknown number of years. And in fact, that's the greatest group of patients that I care for in my palliative care clinic. And what does that mean to live a life knowing that you have something lurking in the background, right? It means that we have to have ways and tools to cope with all of our treatments going forward. We have to have tools to think about how we approach our interval treatment visits, and also tools to honor the work that we're doing between the visits, because you are not the results of your CAT scan. You and what we need to honor is not the result of your lab. What we need to honor is all the work you're doing leading up to that. And so what we try to talk about is thinking about ways to cope with living with cancer, or living with the specter or the ghost of cancer, and move forward and lead a healthy life with positive coping tools so that you're not debilitated or your function is not taken away by those overwhelming fears and anxieties. So these are just some examples of things that we explore as strategies, seeking social support, doing things like the woman-to-woman program, relying on and opening up a social support community, being able to communicate your true feelings of how you're doing with someone, thinking about if you are a spiritual person, are you engaging with your faith practice? Are you engaging with your spiritual community? Many times when people are facing cancer, and sort of ongoing threat of cancer or the stress of cancer, I have found that a lot of people retreat from the things that have always brought them joy and support. And so part of my job is to remind people of the reasons and the places and that they have found those things, and then to also invite them to try new tools to help them tame sort of the things that will come up and maybe overwhelm them while they're walking on their cancer journey. Next slide. So Petra, I asked, has this helped you with your cancer? Absolutely. She helps with the stuff the oncologist doesn't have time to deal with: anxiety, sleep disturbance, pain management. It's nice to have another doctor to talk to. When I first met her, I was a mess psychologically. I feel 10 times better than I felt before I saw her. What's the greatest way palliative care has impacted your life? Stress and anxiety management, the stress that comes from having this illness. Anxiety is harmful, and she helped me manage that. Next slide. So I want to talk about now the bridge. So we're living well with cancer, and then we start to see signs of change. And I like to call this change entering the dying phase of illness. And when I say that, I want to frame it in that we typically see dying happen over the course of months of time. And I can see those changes start to happen with my patients in my oncology practice or in my palliative care practice, usually oriented to around the month's time frame, unless there's something catastrophic that happens, like some critical change. When I start sensing that transition is happening, that's when I start introducing the concept of hospice care and considering a transition to a hospice plan of care. Next slide, please. So I want to bring up this topic of prognosis, or forecasting time and death. You know, there's a lot of fear of talking about death and dying. And also, I think a lot of folks think that maybe there's like, it's mystical, or it's cursing, or it's something bad to see and think and talk about. I want to say there's no magic to it. And I want to invite you all to think about, when you're working with your mentors, what changes do I see? And when I say that, actually, not just our mentors, our family, our loved ones, and to have some cues to recognize change when time might be getting short. Next slide, please. So I say this to my patients in my palliative care clinic, and I really believe it. I do not need a CAT scan or a lab test to tell me when people are entering the dying phase of their illness. And that is because your stories about how you're doing and the way you walk into my office or my clinic here reveal everything. When people have months of life and they're entering that dying phase of illness, we see common things. We hear that they have severely decreased energy. They're spending more than half of their day in the bed or chair, and they're sleeping all the time. They just can't catch energy, no matter what we're doing with medicine, hydration. We just can't get better. There's a severely decreased appetite or desire to eat. I just have no interest. And this is not just like chemo, where chemo kind of diminishes the appetite. It's truly like, I couldn't care if I ate or not. And if I do eat, it's very small amounts. We see difficulty walking, supporting ourselves, dressing, bathing ourselves. We're having a hard time getting to appointments. When I start seeing these things, these are a trigger for me. Other things that we can start seeing is a big critical event happens that changes the trajectory of your illness. You're admitted with a malignant bowel obstruction, and it's after multiple lines of treatment. You're admitted because you have a pain crisis. Usually some big admission like that many times can be a cue that things have changed, and we need to take a step back and reevaluate where we are in our illness, because that could be a cue, if all of these things are happening together, that we are entering the dying phase of our illness, and we need to use a different language and a different approach to care. Next slide, please. A big conversation that's really hard to have for patients and for doctors is when to stop chemo or just disease-directed treatments. And I will tell you that when the body is weak, when you're in the dying phase of illness, we know for sure that chemotherapy and other cancer targeting drugs, and sometimes even radiation therapy, can shorten life. It is the hardest conversation to have with my patients and with other doctors, because not all doctors are cued into this stuff, that chemotherapy at this time will take life away. The whole time it's been associated with more life, less symptoms, and feeling better. If you enter the dying phase of illness and you take further therapy, you will certainly take time away from yourself and end up with worse symptoms. Overall, if you are taking disease-directed therapy in the dying phase of your illness, you'll end up with a worse quality of life and a shorter life. This is, again, to try and untangle this after years of therapy, where chemo equals more life equals feeling better, is very difficult, and it takes time and conversations. Next slide, please. So because we are savvy and we can see that someone has entered the dying phase of their illness, this is the time and opportunity to address what's important to you now that you know time is short. Most people will say, I don't want symptoms knowing that I'm dying. Most people will say, I want to be with my family if I'm dying. I don't want to die in a hospital with a bunch of tubes in me. That is the most common way people want to die, at home, without a bunch of tubes, surrounded by their family. That is the most common way. And I say that not because of my anecdotal experience, but because research has asked people what they want. So when we see that shift happening, it's my job to ask permission. Can I tell you what I'm seeing? I am worried. If I get permission to share what I'm worried about, I'm worried that things are changed. If we take a step back and look at the big picture of the things you've shared with me on your story, your CA-125 number going up, your admission for your bowel obstruction, I worry that you've entered the dying phase of your illness. And I need to know, knowing that time is short, what's important to you now? And if it's those things, then I offer a recommendation. If you're wanting better symptom control, being with your family, and I will add to live as long as possible, then we need to shift our plan of care to support your symptoms and quality of life, because there is research that says that that shift will allow you to live longer than continuing the same course of more chemo. So when I see that, I will offer a patient hospice plan of care. So hospice eligibility, your estimated prognosis is 6 months or less if the disease takes its natural course. 6 months is an artificial number. I can't ever quantify things by a specific date. I can't say, I'm not God, but I can sense that you're in the months range of time. And once I have that sense, then I might recommend this to you. So I would just also caution, don't get hung up on a number that says 3 months or 6 months. That's fake. There's no way that anyone can tell you an exact date. They might give you a range, weeks to months, days to weeks, because you have a sense of a global period of time that someone has. And we have tools that can tailor it when it's getting closer to the end of life with more accuracy. But really, we're talking about months. Goals of care shift, and they're oriented primarily to quality of life, not life prolongation with traditional means, but I'll argue that a shift at an appropriate time to a hospice plan of care ends up with people living longer. And that's supported by research. a symptom control focus as opposed to trying to fix the underlying cause of the symptom. So instead of, for example, I have a fever, instead of looking up with a CAT scan, lab tests, all this stuff, what's the cause of the fever? I'm going to give someone Tylenol. I'm going to put a cool compress on the head. I'm going to help them cool down with a fan. My approach is going to control the symptom rather than try to treat or fix the underlying reason for that symptom. Next slide, please. Something that's really important to know is where hospice care happens, most commonly at home, but know what hospice can provide. And I'll talk about on the next slide. A hospice residence, you still have to pay for room and board if you're in a hospice residence. A hospice benefit only pays for your providers and your symptom-related medicine. A nursing home, you or your insurance pays for room and board. And hospice comes to the nursing facility to support an extra layer of support for the nursing facility. Inpatient hospice unit is not necessarily hospice house. This is very specific. It's like, I call it like the ICU for hospice patients, where an uncontrolled symptom is so severe that it can't be managed at home. Most hospices have an inpatient unit where you can get aggressive IV meds and management of your symptoms. Severe agitation, basically a death that is starting to feel at home unmanageable. These are reasons that people will be transferred to an inpatient hospice unit. Okay, next slide. So home hospice is the most common. What do you get at home? What's the hospice benefit? So it provides nursing support. Hospice is a nurse-driven service. The nurses are the queens and kings of hospice. They take such good care of their patients and see them 1 to 3 times a week, a couple of hours at that visit. And then they communicate with the medical director of the hospice if your meds need to be adjusted, pain medicine, symptom medicines. You have some home health aides, but it's very limited. Less than 5 hours a week in Kansas, unless you have special insurance benefits or you pay out of pocket. This is really like maybe 1 hour a day, a bath aid, something like that. You get a social worker assigned to your case. You get a chaplain assigned to your case, and they are engaged in your care as you determine and want them engaged. There are volunteers. And then, like I said, there's a medical director that oversees the plans of care, but the nurses are the ones who communicate, make changes, argue for things for your case. Home hospice provides durable medical equipment, a hospital bed, oxygen, medications relating to the hospice diagnosis and symptoms, and a comfort pack, which is a bunch of very common emergency meds that you'll need as your symptoms progress over time. Next slide. Okay, so I'm going to pause again, another deep breath. That was a lot. I'm going to check in on our chat and see if there were some questions or any comments that came up during my talk, and then we can invite ourselves to dialogue. So this is one of the most important slides I've seen. People living with chronic disease who have accepted their condition is not likely to be curable often don't know where the line in the sand is. I agree. And I actually like to talk to my patients about this in my palliative care clinic, people who I work with for years and years and years. And they're like, when is the floor going to fall out from under me? And I'm like, well, this is what that floor looks like. And it's very helpful for people to have some idea. I'm like, if you're out playing tennis with your metastatic breast cancer, you're not dying anytime soon. Okay. And so I like to orient us with real facts about like what's happening to your body and when. I'll tell you some things that I do run into. And it's different where you live. When I lived in New York, you could go on hospice and still occasionally get blood transfusions, get paracentesis. There were a lot of things you could get in New York while you were on the hospice benefit that in Kansas, you cannot get. And that is because of the cost of providing certain types of care, contracts to different hospitals and how you get access to that care, and also expertise where you live, it's different. And so I'll tell you that depending on where you live, the care that you have access to may change. Everything, there are some things as far as what people are trained to do and capable of providing, but also financially able to do in the hospice agency that will preclude them from giving certain kinds of care. This is a great question. And actually it's one of our questions that I have prepared from that were submitted. Okay. When I approach my own patients, I think if I can initiate some care for a symptom and then they're stable, my patients are stable with just a preliminary step. I'll start a little bit of pain medicine. I'll start a little bit of neuropathic pain medicine. I'll start a little bit of medicine for nausea, vomiting, and they're pretty stable after that. I think that that's appropriate for your oncologist level of care. If things are not controlled, including for my patients, we need to escalate those doses, or I started that initial care and I can't catch up. That is when I refer to palliative care. And that could be in their first cure-based treatment, it could be, in the middle of recurrence, it could be on their maintenance therapy and they're really struggling. It doesn't really matter when in the course of their disease, it's that I can't catch up with their symptoms. That's one big thing. The other thing is sort of emotional support that it's sort of tricky because I am not a psychologist and I would say I'm a dabbler in psychology. Okay, I can start medicines and I can initiate them, but if you really have a severe mental illness, you need to see a psychologist and a psychiatrist, right? But there's something about total pain, this concept that Dame Cicely Saunders spoke about, that is the practice of palliative care where pain doesn't come from, or depression doesn't come from just that one illness. It comes from all of these components in our life that are not in balance. If you see that kind of like big picture suffering and you sense that, that's also a good time that you want to do a palliative care referral. It is my practice to ask permission to share information of any variety. May I tell you what I'm worried about? And ask permission. So I 100% agree with you about timing and approach, that a patient or a person or your family or your spouse is only ready when they're ready to say, yes, I'm ready to hear, right? Okay, I'm going to share with you information. You still might not be ready to receive it, right, after I say it, but at least we're in an exchange. We actually know, so talking about hope, we actually know that there's been a lot of research about this, that talking about palliative care, talking about hospice care, actually, and talking about things like advanced directives or, preparing for your care at the end of life, even abstractly, actually, it doesn't change hope for patients and families. And that's borne out in data. Doctors are afraid of talking about this because they're afraid of diminishing hope. And that's why surveys and research and qualitative interviews were done to really figure out, does this take away hope? And it doesn't. It actually empowers people to make really good choices for themselves. And then also, people really know where they're at with their illness. And a lot of people are walking around and they're in this like murkiness. I'll ask someone in my palliative care visit, so what did your doctors say about what's happening next? Well, I don't know. Well, why not? Well, I didn't ask them. And I'm like, okay, and your doctor didn't tell you. But anyway, I also want to blow up the idea of hope. And what do I mean by that? Hope and healing have been relegated to the realm of cure for too long. What are you hoping for that's bigger than that? That's different than that? How does hope change and evolve over the course of our lives and our illness? I'll tell you, my great aunt Chancy, who had a stroke, who had a heart attack, who had like lymphedema in her legs, was begging to die and told me and my 10-year-old self at every opportunity, I wish I was dead. Like, you know what I'm saying? Like her hope was that she'd be liberated from her body. And I say that with, but this is the reality. Everyone's hoping for something different at different times in their life. And I don't say that to be glib, but I want to explode the idea of what hope can be. I wish that hope meant more life and longer life, but I also hope that in your life you are living well without pain, connecting with your family and your friends, relying on building connections that are meaningful, doing work that gives you value. I hope for those things. I hope that your healing looks like that you are able to take away your symptoms at the end of life. I hope that your healing looks like you are more connected to your God as you are dying. I hope for those things, and I heal in different ways. And I also explode the concept of miracles, because it can be a miracle to die well. Here is something that I feel like I try to cultivate, I work to cultivate in my palliative care visits, is the concept of love. Like, I don't think we say it enough as doctors with patients. We've been coached that it's wrong to feel love and to feel connection and to feel spiritual tanks being filled up by our connection with our patients, because it's somehow like going against some boundaries of medical, ethical stuff. And sure, we do have to avoid like concepts of like transference and countertransference and sucking up energies, right? But we can sure as hell love. And I openly love my patients, and I don't feel shy about saying that. And when I see my patients suffering, I am suffering with them. And part of my job in palliative care and as a gynecologic oncologist is take a little piece of that pie of suffering and take it on myself. So hopefully it unburdens them a little bit, you know? As a doctor, we often talk about in palliative care, especially when we're talking about this very topic, the principle of like a double effect. I know that this medicine may have this side effect of sedation, and the reason that I'm using it is to manage pain. And I am making a willful choice to manage pain at the risk of this side effect, knowing that the intention is for the primary treatment of pain. And I am going to accept that side effect of the medication, even if it means a heart rate slows, a breathing slows, and the body relaxes. And this is a negotiation that you have with your patient, with their family, about what's the primary goal. If the primary goal is pain relief, then I will accept all of the side effects that come with that pain relief. And in fact, if that side effect is sedation, in fact, like this is an accepted practice if pain is so severe that it is an option to do sedation for a patient. And that is the intention, because any wakeful hour for that patient is severe pain crisis. So it's a conversation that that your will, your direction is based on the primary value of pain control, and that we accept as a community of care providers that if that side effect is a consequence of treating that pain, that is an acceptable risk, and that we're walking in that journey together with patient, family, and caregiver. The other thing that happens when people are doing really well with their symptom management at the end of life and closer to the real hours to days of life is that it is normal that people many times lose consciousness. It is normal that bodies close into themselves. Occasionally, there's some periods of wakefulness, but most of the time, the body sort of falls asleep and falls into itself. And that's normal part of dying. So it actually can have nothing to do with the medicine at a certain point, and everything to do with a normal, healthy dying process. And I'll tell you, here's another secret. Dying is actually really hard. It can be painful. It can be gross. It can be, all these things. It's messy. It's just like giving birth. I haven't personally given birth, but it's just as hard. It's dramatic. There's a huge lead in. It's messy. There's no right way of doing it, right? It's just what is right for you and baby and your team of caregivers. The way in, the same on the way out. And we have to support sort of all of the possibilities that happen in that process. Fear of pain should be taken off the list of fears because, like I said, your pain can be treated to the level of sedation by a skilled hospice team if you elect that. And there are folks, families, patients who elect that level of pain control and sedation so that their bodies can be at peace at the end of life. And that is okay. It is not the medical aid in dying. It is not that. It is not euthanasia. It is not all of these things. The intention is treating pain, and that is totally possible to the most extreme end of sedation. We're all on this journey, right? We're all on it together. It's just a matter of when. And so the more we know, the more empowered we'll be to make it as gorgeous of a journey as possible, acknowledging that it's really hard.